Good afternoon, everybody. We're going to go ahead and get started. Is that volume okay, or did I just startle everybody? Okay. It's 12:02. I know people are still trickling in and grabbing lunch. Please feel free to do so, but we also have a lot of content to cover and just till 1:30 together, so we want to go ahead and jump in. I'm Kimberly Foyle. I'm a genetic counselor at the Medical University of South Carolina and co-chairing our session today on making sense out of CFTR genotyping reports, legacies, stars, and symbols. I know I'm really excited about the increasing applicability of genetics in CF care and precision medicine. And today we hope we'll convey some take-home tools to help you incorporate genetics into the CF Care Center a little more seamlessly. So we have a great speaker lineup of 3 genetic counselors this afternoon. I have no disclosures related to this presentation. I wanted to go ahead and start by asking who is in the room so we can sort of understand our audience and tailor things, knowing if we have a lot of genetics professionals or physician providers, advanced practice providers, or other care team members, patients, or families. So we tried to get deep with the technology and struggled a little bit. I'm going to go old school and just ask for a show of hands, if you will. If you're a geneticist or genetic counselor, I'll pull that group first. Just raise your hand for me. A few, great. And how about MD, physician, center director? Wonderful, wonderful. Nurse practitioner or PA? Great. A nurse or center coordinator? Great. And how about other team members, so dietitians, RTs, rest of the team? Wonderful. And do we have any patients or family members or parents with us? Well, that's really helpful, and we appreciate you all taking the time. We will be using the app Q&A feature for questions. If you open the NACFC app and go to this session, there's a Q&A field and a discussion field. If you can put your questions in the Q&A field, that's what we'll be monitoring here as we move forward. I'll turn it over to my co-chair to get us started.
Thanks, Kim. I'm Langfelder-Schwind. I'm also a genetic counselor at the new Lenox Hill Cystic Fibrosis Center in New York City. I take care of patients from newborn through adulthood, and I'm really pleased to be here as part of this session. I have no disclosures related to this talk, but I am the PI of some grant funding from CFF and Vertex to study genetic counseling. We have, as Kim mentioned, we have a terrific panel of 3 genetic counselors who are going to take us through today's learning objectives. Jessica Balcom will get us started by reviewing CFTR variant nomenclature and clinical interpretation in genetic testing reports, and she's from the Mayo Clinic. And then Karen Rary of Johns Hopkins University will examine how CFTR2 assesses whether a variant causes CF and how the CFTR2 website can be used as a tool in CF variant interpretation. I know that's a mouthful, but Karen's going to break it down for us really beautifully. And then Katie Singh of UC Irvine will discuss some case examples that incorporate all the things that we've been discussing into patient diagnosis and care. So our first speaker will be Jessica Balcom of the Mayo Clinic. And as Kim mentioned, we'll be going through the questions that are coming in through the app, and expect we'll have some time to address 1 or 2 of them after each speaker speaks for about 15 minutes. And then at the end, we'll have some more discussion for all of the speakers. Jessica? All right. Let me get your slides up. Yep. It's Balcom. Okay.
Great, thanks for having me. I'm really excited to be able to kick things off today and to see such a diverse group of you sharing your lunch hour with us. I'm gonna time myself because I could talk about all of this all day, so I got to keep myself on task. I have no disclosures related to this presentation. Again, the portion of the talk that I'll be focusing on is related to variant nomenclature and interpretation of genetic test reports. There's me. These are the overall educational objectives for our session today, and my portion will focus primarily on the first objective, to review CFTR variant nomenclature and clinical interpretation in genetic test reports. I would like to start by orienting us to why this is important, why it matters for all of us in CF care, what makes it so complicated, and then hopefully some more practical pearls of wisdom to take away for interpreting genetic test reports. So starting out, orienting us to the topic, a mini clinical vignette. Of course, we know in the era of modulator therapy, genotyping every patient is essential for us to determine eligibility. And so basic question that is encountered with our CF patients is, does this patient qualify for modulator therapy based on their genotype? So here's an example genotype, homozygous 1653 through 1655 del. If you were to put this into the eligibility search function online or look at the listing of mutations that are eligible, this would not come up, but it is actually one of the iterations for describing F508 del. And so indeed, this patient would qualify for modulator therapy based on their genotype. In the context of our CF care, it is essential as providers or caretakers that we are able to recognize all of these different iterations. I think Dr. Dara mentioned, there's at least 6 different ways that F508 del could be described. I think I have maybe even more than 6. So all of these are ways that you might see this one single mutation depicted, including the one from the vignette. And so it's essential that we recognize that regardless of what F508 del is called, it would still be eligible for modulator therapy. In addition to the imperative aspect of determining patient modulator eligibility, it's important that providers have an understanding of nomenclature and accurate interpretation of genotyping for a few other reasons. The second bullet point here is maintaining integrity of medical records and patient databases. So as different providers are entering their documentation for the patient and calling out what their genotype is, ensuring that that's consistent and accurate is important to make sure that that continuity is there for recognizing the patient's status, as well as maintaining the accuracy of our various databases, so entries into Port CF, utilizing the data available in CFTR2 are all contingent on an understanding of the nuances of the genetic nomenclature. This is also relevant when we consider testing beyond the diagnostic testing for the patient with CF. So anytime that we are facilitating cascade testing for other relatives of our CF patient or for a partner in a reproductive care setting, again, essential that when we are requesting testing for the mutations in the patient, that we are conveying the accurate information to the lab that will be testing other family members. And then specifically in the scenario that a couple may be pursuing preconception or prenatal testing to diagnose an at-risk pregnancy, again, understanding what we're testing for and conveying that information accurately is imperative to get an accurate result. So hopefully that brings us all on board with the importance of this topic and the relevance for everybody, whether you're a genetic specialist or not in this field. The next segment that I wanted to touch on is, why is this so confusing? Why are there 6+ names for F508 del mutation? And I'll talk about 3 different factors that influence the complexity of genetic nomenclature. The first 2 are applicable to all molecular genetic nomenclature, and then the third one is a CFTR-specific nuance. So first, one of the reasons that this becomes really complicated and why a lot of times providers looking at reports will come away with some sense of like there's just a lot of gobbledygook, a big block of random codes and symbols. Part of that is because at any given position in the genome, you can describe a variation at multiple levels. So referencing back to the excellent plenary talk yesterday, Dr. Dara went through this description of how DNA is processed and changes in the course of being transcribed and then translated into protein. And that relates to the different ways that we name variation in the gene, in any gene, not just CFTR. So the first figure here is showing the genomic DNA, so all of the coding and non-coding DNA depicted in blue for coding and yellow for non-coding. If you were to start at 1 and number every nucleotide of DNA in the CFTR gene, including all of the coding and non-coding, you would have numbering system from 1 to 187,000. Once the DNA is processed to remove the non-coding portions of the gene, of the genetic code, we're left with the coding sequence. And in terms of the way that this is depicted on a report, this is called the cDNA numbering scheme. And so in this case, we're taking just those blue portions, and that would number 1 through 4,443. So we've lost a lot of the DNA when the intronic sequence is spliced out. And then finally, the RNA version of the DNA is translated into a protein. Within that process, every codon of 3 base pairs becomes 1 amino acid. And so the numbering at a protein level is 1/3 of the numbering at the DNA level. And so you can number CFTR, again, based on that genomic, all of the DNA sequence. You can number it based on just the coding DNA, or you can number it based on the amino acids that comprise the final protein structure. Oops. So if we zoom in to a very specific segment of DNA in the CFTR gene, if we were to look at one triplet of CTT base pairs and delete that out of the sequence, there would be 3 different ways to describe that mutation if we're looking at the genomic level, the DNA coding level, or the protein level, and that's shown below. So the genomic DNA change is very specifically orienting someone to where in the extensive DNA sequence that change occurred. The cDNA is referencing just the coding DNA, and then the protein change, I don't know if I have a pointer, I don't think so. So the amino acid or protein change is describing that variant at the level of the amino acid or triplet. And so oftentimes in a report, you'll see a block of text like that, which is all describing the same thing, the F508del mutation. And that's true whether we're talking about CFTR or any other genetic testing and nomenclature. The next factor is also applicable to any gene that we're testing. And this one is the evolving molecular nomenclature standards. So the organization that sets the standards for how we depict gene mutations in genetic test reports is HGVS, the Human Genome Variation Society. Over the years, they've had multiple iterations of their recommendations that have changed the standards for how we would describe the same type of mutation. One of the challenges is that they are not necessarily on a set cadence for versioning their recommendations, and so we can't necessarily anticipate that once a year or once every 5 years they'll come out with their set of new recommendations. These are really dynamic and evolving continuously, and so as a clinical lab, any given lab may be more or less up to date with the most recent iteration of how we should be using this terminology. So this is kind of the call out to our title of our session, Just a few of the examples of how different recommendations will show up in our description of gene mutations. So the way that we are recommended to depict a termination codon or a stop mutation, a nonsense mutation, has been recommended variously over the years as ter, stop, X, or this asterisk. The asterisk is technically the correct designation, but for CFTR, I think it's very, very common still that you'll see G542X, that you'll see the X used. I know our newborn screening reports that I get still have the X. A lot of test reports do as well. And I think the listing of eligible mutations still uses the X designation. Amino acids can be abbreviated with 1 letter or 3 letters. So your F508del would more accurately be described as Phi508del. And the guidance for describing more complex mutations that aren't just changing one base pair to another, where you're deleting or inserting or duplicating, have kind of been all over the place over the years. So again, these are all different ways to describe a deletion of 3 nucleotides at position 1521, 1522, and 1523. So the last one is the one that's consistent, the 1521 through 1523 del is the most accurate way to describe the DNA change that leads to F508 del, but the others are still commonly seen as well. So those are the 2 factors that are applicable to any gene that we're testing or describing. The last one that I'll talk about is special for CFTR. So with CFTR specifically, there is a legacy numbering scheme that also leads to different ways of describing the same change. So I mentioned in the first number 1 factor that when we look at just the coding regions of the DNA, we can list the numbering starting at 1, and the 1 would designate the very first nucleotide that's part of the first exon. That in and of itself is a new-ish convention. And so back in the days that the CFTR gene was first characterized, the way that it was numbered initially included a little bit of that non-coding DNA in the regulatory region of the gene. And so initially, the way that mutations were described in the CFTR gene had that 1 position a little bit before the start of the coding DNA, and the start of the coding DNA was position 132. And so subsequently, all of the other positions would be offset by 132. So this is very specific to the way that the DNA was described for CFTR. So if you're talking about a protein level description like F508 del, that's not impacted by this legacy naming convention. But for the DNA level descriptions, this does come into play. And so for the recurrent splice mutations that come up frequently, those will have different DNA conventions if you're using this legacy or not. And the legacy is still highly prevalent. It's really recognizable to more practitioners oftentimes than the newer numbering. This is just a different way of looking at that. So here is the sequence of the CFTR gene. And again, showing that whether you start that numbering actually at the first coding exon or not, you'll be offset. And because of that, you can describe the DNA change that leads to F508 del alternately as a deletion at positions 1521 through 1523, or using the legacy numbering as 1653 through 1655. And so I think with that, we've accounted for all of those different versions that popped up in the earlier slide of how you can depict F508 del. have an analogy next that I'm a little bit daunted to present after Dr. Dara had her amazing cheesesteak analogy, but I will still go for it. So these different levels of describing a mutation, I think can be thought of similar to how you would give directions or describe a location. So there's a really familiar sort of descriptive colloquial way you could describe, where's the Pennsylvania Convention Center? If somebody's local and familiar with the area, you could give them a descriptive directions. If they're not, someone's gonna be driving in, you'd probably give them the address so they could put it in their GPS and find it. And if you wanted to be really technical, you could provide the precise coordinates for the location. And so bringing this back to our different nomenclature, you've got the really familiar protein level change. That's usually what people recognize. The cDNA change orients you more specifically to the DNA, and the genomic change orients you to the very precise location amongst all 20,000-ish genes in the genome. And so that's really important when we talk about testing, taking a test report and trying to, for example, test other people in the family for it or facilitate fetal testing. The laboratory needs to have that precise coordinate to ensure that they are going to test the exact region. And so one of the reasons that lab reports are so confusing is because they're trying to meet the needs of multiple different audiences of the report, so to speak. So the lab report is going to be seen by the clinician who needs to orient themselves to what's there. It may be seen by the patient as well. And it also needs to have the precise information to ensure that another lab could replicate that testing. I did talk too much, so I'm gonna just go through this pretty quickly in terms of some of the ways to anchor yourself to a report. And so this is an example of a sequencing report. And so there's a lot going on here and a few things to consider when you are orienting yourself to a report. Oftentimes there's kind of a quick glance or result summary. So positive, so you know you're looking at something. It's not necessarily super specific. And so if we dig in more, some of the clues when you're looking at that result is a big block of text. What does that represent? Is it multiple mutations, one mutation, orienting to the fact that it's calling out homozygous? We're looking at 2 copies of a mutation. The variant classification is important, and Karen will touch more on the significance of that. It's important to be able to recognize if the report is giving you alternate nomenclature, other ways of listing the same mutation that was in the result, versus actually giving you additional information. And so oftentimes the intron 8 poly Ts will be in a different section, and knowing, are you looking at something that's a distinct result or just a different way of saying the same result? And then the interpretation, again, I think Karen will touch more on the importance of not just recognizing what the mutation is, but how it should be clinically interpreted. And so the last piece that I'll touch on here is the importance of looking at the method. So when you're looking at a result, this one happens to be definitive, it's homozygous F508del, but if you don't have a definitive result, if you have 0 or 1 copies of a mutation, it's important to be able to find where the method is described to know how comprehensive was that test, what's been ruled out by this negative or inconclusive test report. This is just a different version of a report and how it might look different. So every mutation name has multiple versions. Not all of those versions will be queryable in any given database that you're looking at, and so it's important to know what those synonyms are or be able to translate it. And these are some of the key pieces of information to extract from a genetic test report as a provider. That's what I had, and I'm guessing we'll move ahead with the next speaker maybe, because I talked a long time.
Thank you, Jessica. That was wonderful.
All right, so that was a very high-tech talk, and our high-tech question app doesn't seem to be working properly. So once again, we'll go back to the old school. Maybe, do we have time for a question or two?
I think we can take a couple now.
Does anybody have something really burning that they want to address right now? If you want to raise your hand, we'll. Okay. All right, we'll bring all the speakers back at the end of the session and have some discussion. All right, thank you so much, Jessica. Our next speaker is Karen Rary of the CFTR2 project, and I will welcome her to the podium. First, I'll get her slides up.
All right.
Can I interrupt you
Okay.
1 second?
Yep.
It looks like our new QR code is arriving, so perhaps we'll be able to put questions in the app before the end of Karen's talk.
We'll find out. If not, we'll just yell them out. That's what we're used to. Well, thank you very much for the invitation to speak today, and I'm so glad that Jessica set us up so nicely with nomenclature, because I'm also going to mention that. And in true genetic counselor form, I'm going to say some of what she said again, because you need to hear things multiple times. Did we decide how we advance the slides? Use the arrows. Okay. I have grant funding from the CF Foundation and from Vertex. So my learning objective today is the second one in our list, and to examine how CFTR2 assesses whether a variant causes CF and how the website can be used as a tool in your toolbox. And so I'll start with just a very, very brief overview of the CFTR2 website and remind everybody in about one sentence what the project is. Go through our definitions of terms and then our assessment process and talk about how that can help you in your practice. So for those of you unfamiliar, which I hope is not many because I think CFTR2 has been around for quite a while, but this is just a quick reminder that the CFTR2 project aims to collect genotype and phenotype information from individuals with CF worldwide to essentially figure out what their genotypes are, make a list of those variants, and then work our way down that list in order of frequency to define whether those variants cause CF or not. And then to make that type of information available to CF researchers, clinical providers, the CF patient and family community, others, et cetera, on a publicly accessible website. So the website address is right there, and we have two sides to it. So we have a healthcare or science view, a general user side. The information from both of those sides comes from the same source, but it's a little bit more granular on the healthcare provider side. And I think we decided we don't have a pointer. Maybe I do. Hold on.
You want me to point?
Nope, I got it. Can you see that? Okay. So up here, right under your Enter First Variant search box, there's a little bar that says click here to switch to Healthcare or Science View. That's how you swap back and forth between the two sides of the website. And this is just a quick snapshot of what you might see if you go to the CFTR2 website. If you go there, so for all variants that are searchable on the website, we provide information about nomenclature that we actually don't provide the genomic location. Maybe we should, but we do give you the cDNA name, the protein name, and also the legacy name with that legacy numbering system that we just heard about. We'll also tell you what the variant does, whether it causes CF or not. We'll provide clinical information from individuals with that variant, any sort of functional testing results if we have them, or a statement about functional testing, and then our history of interpretation or final calls on the variants. And then for some variants, we also have additional information on modulator eligibility, non-penetrance, which don't worry, I'm going to explain that very genetics-y term in a few slides, and then additional special notes, if necessary, about complex alleles or really unusual aspects of a variant, and then some references. And this is just another screenshot of a specific variant pulled up onto the website, and you can see that we give you all our nomenclature up here, we tell you what it does here, and then you can click on these individual tabs on the healthcare provider side to get additional granular detail about each variant. And at the bottom of each page, we'll tell you whether that variant has had a change in call over time. That doesn't happen very often, but occasionally it does, and that's all cataloged on the website here. So when I talk about CFTR2 interpretation of a variant, we have four main categories. The first is the most obvious and the one that I think really nobody has trouble understanding, and that's a CF-causing variant. And what we mean by this is that if you have one CF-causing variant in one copy of CFTR and another CF-causing variant in the other copy of CFTR, we expect that that individual will meet the clinical definition of having cystic fibrosis. On the flip side, we have non-CF causing variants. And these are variants that when you find them in one copy of CFTR, and that patient has a CF causing variant in the other copy of CFTR, we actually don't expect that person to have CF. Now, they may have a CFTR-related disorder, they may have some mild symptoms, they may be completely healthy, but we don't expect them to have cystic fibrosis. Somewhere in between those two categories, we have varying clinical consequences. Those are variants that cause CF in some people, but not in others. They may cause CFTR-related disorders. And then lastly, we have an unknown or indeterminate category. Basically, when we can't bin something into those first three that I described, we call it unknown. So that's all well and good, except you just saw from Jessica's talk that in the lab reports, we often don't see the terms CF causing, non-CF causing VCC. We see things like pathogenic, likely pathogenic. And so how do we sort of equate these? Again, I think the most obvious is that when something is either pathogenic or likely pathogenic, those are variants that we would typically call CF causing. When a lab calls something benign or likely benign, skip ahead just a sec, those are usually variants we would also call non-CF causing. And VUS, or variant of uncertain significance, is pretty self-explanatory. So that means we don't know actually what it does. But you'll notice there's one term up there that doesn't have a nice little arrow, and that's varying clinical consequences. So we call these VCCs in CFTR2 speak. And I think it's really important to note that a VCC does not equal a VUS. So something that causes clinical variability and that we know about is not the same as a variant of uncertain significance. So I just want to make sure we don't equate those two terms. But unfortunately, we don't really have a good equivalent for how to call VCCs on a typical clinical testing lab report. So most of the clinical terminology used in these genetic test reports are from the ACMG, so the American College of Medical Genetics and Genomics, and they're the ones that sort of prescribe that you should call something as pathogenic, likely pathogenic, benign, likely benign, but they don't have an equivalent for VCC. And so we just need to keep in mind that these are really tough variants to interpret and to really make sure that you sort of read about them on the website and see what we can say about them. As I said, these are different than uncertain significance because we do actually know about them. We just know that they're variable. And usually these are variants that result in reduced penetrance and or variable expressivity. So those are two very genetic-y terms, but essentially what they mean is that they don't cause CF in every single person. And when they do cause disease, it might look different from person to person. So how do we get to these names in CFTR2? So I'm going to kind of fly through our process because I'm happy to go into it in more detail later, but just in the interest of time. First thing we do is populate our very large database of 90,000 or so individuals with CF, figure out how to prioritize the genotypes and the variants listed in order of frequency, and then we use three different methods of interpreting things. So clinical data from people carrying a variant of interest, functional testing of that variant in a laboratory, and then population and penetrance studies, assessing how many people in the general population might have one of these variants and do or don't have CF. And so when we think about how we might call something CF causing, the number one thing we want to do actually is look at a variant in the context of another variant, right? So cystic fibrosis is recessive, and in order to have it, you have two genes and you have two individual mutations. And so we have to figure out how to evaluate one in the context of the other. So typically what we do is when we have a variant of interest that we want to evaluate, we have to find it in somebody who also has a CF-causing variant in the other gene that causes almost complete loss of function, because we want sort of a neutral or a blank slate to evaluate our one variant of interest on. Now, lucky for us, delta F508 has almost no function and is quite common. So most of the people that we evaluate, when we're looking at a variant of interest, most of them have delta F508 or something similar on the other CFTR gene or the other allele, and that gives us a nice kind of neutral background. What we're looking for to call things CF causing are people with a mean sweat chloride of more than the diagnostic threshold, so 60 or more. We want to see less than 10% functional testing of normal CFTR. We know below that threshold is when we start to see features of CF. And we want to make sure that there's no evidence of non-penetrance, which is maybe the worst way to describe something. It's a double negative. But what it means is that what we don't want to see is somebody with a CF-causing variant and then another variant of interest that we think causes CF, but the person doesn't actually have disease. That would be an example of non-penetrance. So when we want to call something CF-causing, we want to make sure we don't hear about or see population evidence of people running around that don't have disease when we think that they should. So I'll give a very quick note about functional testing, and this will reiterate some of what you just learned. Not all CFTR variants require functional testing. There are specific variant types that we expect lead to no protein production. These are frame shift variants, nonsense variants that you can determine are nonsense because they might have an X or an asterisk or a stop or a ter. Exon deletions and duplications where you're missing large chunks of the gene, those don't produce any protein. And then canonical splice variants, and if you remember nothing else about canonical splice, we're talking about plus and minus 1 or 2. And so with few exceptions, these variants have essentially no CFTR function. We don't functionally test them as part of our protocol. And I've just highlighted in red here sort of the key things that you can pick out from these legacy names. These are specifically legacy names for the most part to try to recognize these variants. So in my last 5 minutes or so, I want to go through some examples of different types of variants within CFTR2 and just sort of how we apply these assessments. So for an example, for a CF-causing variant, we have L206W. This is the legacy name. We have it in over 300 people in CFTR2, and 312 of them have it on the genetic background that we want to evaluate. So these are people that have one copy of L206W and one copy of something that doesn't have a lot of function, like delta F508, G542X, et cetera. The mean sweat chloride of this group is 68 milliequivalents per liter, so that ticks our sweat chloride box. The functional testing of this variant in the laboratory shows that it conducts chloride at just under 6% of normal, so that ticks our functional testing box, it's below 10%. And we, again, the double negative, we have no evidence of non-penetrance, so we don't think that there's anybody running around who has L206W and a CF-causing variant who doesn't have CF. We don't think that that exists. And so that ticks our population and penetrance analysis box. We've now met all three criteria to call this variant CF-causing, and so that's what you'll see if you look it up online. Now, if we go through something that's a little less clear, I'll use P5L as an example. Variants of varying clinical consequences essentially just do not meet all of the criteria to be CF-causing, but we must have some evidence in the database that at least some people appear to have CF, so diagnostic sweats, lung disease, pancreatic insufficiency. So for P5L and CFTR2, we have 47 people who have this variant and also something that has low or no function. The mean sweat chloride of this group is 69, and so that ticks our sweat chloride box. The functional analysis shows that P5L actually conducts chloride at about 22% of normal, so we don't get to tick our functional analysis box. And our population and penetrance analysis indicates no evidence of non-penetrance. We think that everybody with this variant probably has CF, even if it's a little bit mild. So we do tick that last box, but you can see we don't get to tick all three here. But given that we do have evidence in CFTR2 that some people have CF, we have reached the conclusion that this variant causes CF in at least some people, but maybe not entirely in others. And so it gets the designation of VCC. Where it gets a little bit more complicated is calling something non-CF causing. These variants don't meet all the criteria to be CF causing, that part should be fairly obvious, but they also have to have some additional characteristics. So either a variant that we call non-CF causing has to have function of at least 75% or more, or evidence of non-penetrance. And I'm going to go through an example of this. I keep throwing out that term, but I'm going to hopefully drive it home. So in CFTR2, we have R75Q. We have it in 36 people who also have a delta F508, W1282X, something like that. The mean sweat chloride of this group is 58, so we're below our 60 threshold. The functional analysis is pretty darn high. It's got 65% function. Now that doesn't meet our 75% threshold, but I'll go through the non-penetrance in a minute, but it clearly is not below 10%. And we did a penetrance analysis as part of the CFTR2 project, and we found that there are 48 fathers of people with CF who have R75Q and another CF-causing variant, but these people don't have CF or any CFTR-related manifestation. So how did we do that? So we looked at families, essentially. So we've got a child with CF and her father in this example, and we know her genotype. We know she's got one copy of delta F508 and one copy of G542X. That's pretty straightforward. Then we genotype her dad, and he's got one copy of G542X, but he's also got R75Q. Now, she doesn't have R75Q, so we know that it's on the other CFTR gene in her dad, and we also know that he's healthy, he's fertile, he's got vas deferens, he has no CFTR-related symptoms. Now, we know G542X very clearly causes CF, so the conclusion is that R75Q in this person is non-penetrant. It means he does not have CF, it doesn't cause CF in him. And so these are the types of data that we consider when we call something non-CF causing. Quick caution about non-CF causing variants. They, of course, exist in people with CF. They just aren't the cause of CF in that person. But so when you see somebody that has either only non-CF causing variants or maybe at least one, it doesn't exclude the diagnosis of CF, but maybe it prompts a reevaluation of symptoms. And so this is just a made-up example here of a 17-year-old with CF. He's been followed for years. He had one high sweat chloride back in the day. And he's got these two variants, G576A and R668C. Some of you probably recognize this. And he's got these kind of mild clinical features. He's got some sinus disease and these kind of nonspecific GI complaints. So he shows back up and somebody says, let's reevaluate because both G576A and R668C don't cause CF. So you re-sweat him and it turns out his sweat is normal. It turns out his two variants are actually inherited from the same parent. So they're together in the same copy of CFTR. He doesn't have anything in his other CFTR gene. He's still got some sinus disease, but his GI symptoms have resolved. He probably just doesn't have CF. And so when we see patients that have non-CF causing variants, we really need to look hard and say, do they actually have CF? Maybe not. And if they do, let's figure out what the cause is, because it's not the non-CF causing variant. Lastly, we have variants of unknown significance. These are exactly what they sound like. We can't figure out what they do. They either have conflicting data or they just don't have enough to sort of get us over the hump of calling them something else. If you ever have any of these and you want to reach out to our team, we will typically tell you why we call something of unknown significance. Often we have some data and we either can't reconcile it or just can't figure it out. I'm happy to share that. So how can CFTR help you? So it can aid in a genetic diagnosis, of course. We know that you can actually diagnose somebody with CF if they have two CF-causing variants. You then need to confirm it with a sweat test. But this is really helpful in infants, especially if you can't sweat them or you can't get enough sweat to get a good value. CFTR2 can help provide anticipatory guidance about a general phenotype expectation. Of course, we can't say this is what one individual person will do over their lifetime, but you can get a general sense of whether they'll have pancreatic insufficiency or not from the clinical data that we provide. And we do provide information about modulator eligibility. I would also recommend, you're probably familiar with the Vertex treatments page where you can just plug in your variants and it'll tell you whether there's a drug for it. Very briefly, I want to touch on the role of CFTR2 in non-CF diagnoses. We don't have one. So we rigorously assess whether variants cause CF, but we're not specifically set up to assess CFTR-related disorders. We don't collect, we're trying, but we don't currently have information about pancreatitis, bronchiectasis, infertility. So we can sort of have a gut feeling sometimes, but CFTR2 is really not designed for that. We're specifically looking at individuals with CF. So I'll finish just with my take-home points here. The website is freely available to you and your patients and families and anybody in the CF community. We provide lots of what we hope is useful information. We do use pretty rigorous criteria to assess different variants, and we're hoping that these interpretations may aid in diagnosis, better anticipatory guidance, and selection of modulators. And I'll just acknowledge the CFTR2 team for all of their help and support. Please feel free to reach out to me with questions. Are we taking any now? And I'll stop there.
Thank you, Karen.
Okay.
So we have good news. It looks like the app is starting to work. So if you have questions, please put them in. I also wanted everyone to have time to get Karen's email address. And also, do you want to make a comment about the contact me feature of CFTR2?
Yeah, I should have put a slide in. Yeah, so if you go to the CFTR2 website, in one of our search bars up at the top, there's a contact us button. And that will take you to kind of a form email page where you can put in your email and then there's a box with a question. So that goes to the CFTR2 email address, which I monitor. And generally speaking, even if you can't find a variant online or you have questions about something online, we often have additional information that we can provide with more context. So some things are just really tough to explain on a website, but if you have a little bit more personal interaction, we can give additional data sometimes. And so please feel free to use that liberally. We're happy to share when we can.
The other thing I just want to comment, I use CFTR2 like a Rosetta Stone. I speak legacy name with CFTR mutations, so often the center directors I work with will say, oh, I got this, result. What does this C dot mutation mean? And sometimes I don't know off the top of my head. I can usually recognize the Delta F508s, but not always all the other ones. So that's what I think of it as, like a Rosetta Stone.
Yeah, and you can search for any of those nomenclatures you can put in and it'll pull up sort of all of the different versions of it. So you can search using a C dot term, a P dot term, a legacy term.
Thank you. So we'll come back with all of the questions after our last speaker, who I think will give us some clinical applications. Katie Singh.
I get the fun part.
Oh, do you want?
I think I do. I pressed open. Yes, okay. So I have no disclosures. Okay, so my goal is to tie together everything you just heard and bring some case examples to help teach how it all works together and what you'll have to do when you're actually in the clinic. And I also put in some special potential pitfalls that you may experience. Okay, so first case is a 9-year-old girl who was diagnosed with CF in infancy due to failure to thrive and a family history of CF. Her dad had 2 siblings who are now deceased, both who were homozygous for delta F508. Dad is a known delta F508 carrier. Her sweats were 95 and 91, and her clinical picture completely fits a diagnosis of CF. So in the age of modulators, genetic testing is done, and it's a surprise. So she undergoes CFTR sequencing, and only one heterozygous variant is identified. So I'm going to ask you, through our very fancy polling system of your arms, how do you interpret these results in the case of this situation? So 4 answer choices. I'll read them and then I'll go through a show of hands. So A, she doesn't have CF, she's only a carrier. B, she has CF. She probably has a deletion that was missed because only sequencing was done. I'm gonna read them all and then I'll have you raise your hands. C, she has CF. There's high suspicion for a lab error or non-paternity. Or D, no idea, you're here to learn. So takers for A. Okay, well done. B. Okay, a good number, I can't count. C, fewer than B. And D. I think I appreciate the honesty. So the answer is C. She has CF, as we can tell by her sweat and her clinical features. There's high suspicion for a lab error or non-paternity here, and I'll work through why in a moment. So what did I do with this? So I first had a private discussion with the mom to make sure that there's not non-paternity. Those are not easy discussions to have, and you never want to do them with both parents together. So after a conversation with mom, it was very clear that he is absolutely the father, so that was off the table. I should also point out Karen's example of the little cartoon of the father and the daughter is really relevant here. Dad has no symptoms. Dad is already a known carrier of delta F508. This mutation that's here, even though mom hadn't been tested, is definitely CF causing, the one that was found, so it couldn't have come from dad because he wouldn't be fertile and he would have had symptoms. So we know that this mutation was maternally inherited, which is why I'm singling out non-paternity versus non-maternity. So that leaves either a de novo mutation, which I didn't put in the answer choices. De novo mutations are possible. They're very rare. They're probably a lot more rare than lab error, unfortunately. So I called the lab and had a discussion with them about the case, gave them the scenario, asked them to take another look at the region, especially around delta F508, given that her a priori risk to have that mutation was 50%. And I got a phone call back from the lab a few weeks later. They were issuing a new report confirming that she actually does have delta F508. So the new benefit here is that it made her eligible for Legacies IVA, which was great for the family. There was a small delay in that because of this situation. And I think I need to pause here so that you guys don't all walk out of here thinking that the most common mutation in all of CF is easily missed by a lab. It's the only time I've ever seen this one missed, but the point is it was missed. There's human error throughout the process of testing, and errors can happen anywhere along that process. And I don't know exactly where this went wrong. The lab was not very forthcoming with that, but I suspect it was human error. And so my point with showing this case is that if something doesn't fit, it's appropriate to question it and to go back and try to figure out where it doesn't work, especially when the outcome here was the child was drug eligible, and it's a major difference to her care. Okay, so case number 2, instead of finding 1 variant, we're gonna find 3. So we have a 10-year-old girl who has CF that was diagnosed late at age 7. I shouldn't say late, she was picked up by newborn screening, but she converted from CRMS to CF at age 7. And her most recent sweat was 64, and that's what led to the conversion to CF. Her clinical presentation is consistent with converting from CRMS. She's on a more mild spectrum, but she does have some disease. And she undergoes CFTR sequencing with del-dup this time, and her testing finds 3 variants, not the 2 that you would typically expect. And so she's modulator eligible based on these mutations. And the family then, in appreciating that she's modulator eligible, questions their 2-year-old, so her little brother, who had a normal newborn screen because his IRT was normal, and he's clinically asymptomatic. But given that she's now eligible for this and they've read a lot about modulators and see the benefit, they want to know, well, what does this mean for him? And so they want him to have testing. So he undergoes familial variant testing for her 3 variants, looking to see which, if any, he has, and he has 2. And I have highlighted, because of what you've learned so far about how many different names everything has, to keep it as unconfusing as possible, I bolded the more common legacy name for them at the bottom. So now it's your turn to tell me how to interpret this. How are we going to interpret what this means for the brother? So I'll give you a second to take a look at it. So A, he has CF. B, he has CRMS. C, he's a carrier. D, parental testing is needed to answer. Or E, again, you have no idea, and hopefully we'll teach you. So A, okay, B, C, D, E. Okay, so some of you got it right. It's D. You have to do parental testing, what we call phasing. So trying to figure out the configuration of those variants. So I'm going to walk through that with you here. And Karen, how'd you get that pointer? Do I just move all the way? There we go. Okay. So you've got in the girl, we know she has 3. So we know that she only has 2 copies of this gene, so 2 of them have to be hanging out together in cis. But we don't know which 2 are here versus which one is here. So the way we figure that out is we test the parents. And down here, we know that he has 2, and we know that he has D1270N and R74W. But are they sitting like this, opposite, in which case he would be at risk to develop CF? And I'm saying at risk because he's asymptomatic, had a normal newborn screen, and has mutations that are not always significantly disease-causing. Or he's a carrier of 2 over here together. And the implications of that difference are massive. So we test the parents, and we find the face. So we know that D1152H is by itself with dad up here, and mom has a compound allele with these 2. And so what does that tell you for him is that it has to be this one because he inherited that allele from mom. He does not have D1152H, so he got the other 2 from mom. So that defines him as a carrier. And it also gives information about resolving the phase for the proband, which may be important for her down the road. So I'm going to show you some clues. So some lab reports do a good job of hinting you to this possibility and others do not. So I've got several examples here, and I will say the further back you go in terms of how long ago testing was done, you're less likely to get the clues because we're starting to adopt, there are better guidelines that dictate what should go on a lab report. So these first 2 examples, if you happen to have these as the result for that child, the report basically would have said he has CF. He has 2 mutations, he must have CF. No clue on here about needing to determine the phase or test the parents. And I apologize for the poor quality of some of these. They've been faxed many times over. So this one, if you draw your attention to the blue box, it does have a bullet. So the combination of these alterations would be expected to cause CF or a CFTR-related disorder if they are on different chromosomes, and that means intrans. So that's a clue that you need to go back and look at the parents, which honestly should be done in most cases, even if the report doesn't tell you. And then essentially the same thing here, although they add on to that further to tell you how to do that. So parental testing could confirm. This one says essentially the same thing, although worded slightly different and buried in the middle. It's not as clearly called out. And then perhaps the most clear doesn't even call it a positive report. It's called potentially positive. And they clearly say the data from this test cannot definitively determine if the CFTR variants are on the same chromosome or opposite chromosomes. Testing parents and/or additional informative relatives for these variants could assist in determining the phase. Caution should be used when interpreting this result until the phase of these variants is resolved, which is exactly the case that we just showed with that case example for the brother. Okay, so switching gears to another case. A 6-year-old girl is diagnosed with CF in infancy by newborn screening. She also had a meconium ileus, and her sweats are in the diagnostic range, and her clinical presentation fits with CF. She undergoes testing to determine if she's modulator eligible and has 2 pathogenic variants, and the clinic works with insurance to request authorization for Alex-T-Zyba. But it's denied. And the denial states that it's not medically necessary. They do cover this drug, and they have approved criteria for it as long as someone has one of the following variants. And there's a whole list. So what I'll do is bring back her mutation report so that you can compare. And then I'm going to ask you, did the insurance company appropriately deny coverage based on the genotype? The answers are going to be yes, no, and I have no idea. But because there's so much up here, I'm going to leave this up for a moment. So I'll take a show of hands for yes, it was appropriately denied. No, it was not appropriately denied. And I'm going to guess that the rest of you didn't get enough time to look at that slide, or it was just, okay. So the answer is no, it was not appropriately denied. There we go with double negatives again. It was inappropriately denied. So this variant here, and you'll notice I didn't bold anything. It doesn't have a common legacy name, and the whole thing on the bottom from the insurance company is all legacy names. But if you take a look over here where the giant purple arrow is, I502T is the same as isoleucine swapped out for a threonine at position 502. And so it's really there, and they really do cover it. They just didn't know when the report was sent that it was the same variant. And so whoever was reading this at the insurance company didn't understand what they were looking at, which is not uncommon. And so this was an easy argument on an appeal, but it takes extra time. It goes through a process. It causes a delay in care for the patient. And so these are some screenshots from the Vertex tool just showing, and also from CFTR2. You can actually search by just, the way I usually search is taking just the numbers. So you don't have to start with searching from the very beginning because that might limit you in terms of what you're finding. You can search for a piece of a variant and see anything that's a hit. And here the first 4 are actually a match, but the bottom one is not. So be careful. If you just put in a piece, it doesn't mean everything you see is a fit, but it'll show you some examples. And there are definitely other variants that aren't going to be as comprehensive here, so you won't always see them all, but it's a good starting place. And again, as Karen already highlighted, CFTR2 will also give you good information. Okay, so my last case is a 28-year-old man who was diagnosed with CF many years ago as a child. His sweats were in the diagnostic range, and his clinical picture very clearly fits. He presents to a new center and wants to know if he's eligible for modulators. No one can find any record of him ever having been genotyped during childhood, so testing is sent. And testing is sent and interfaces electronically into the EPIC system. So the clinician reviewing the report notices the very first line of the report that calls out recognizable variants of R117H and 5T, recognizes that the R117H makes him eligible for ivacaftor and prescribes the drug. The patient has a PPO insurance that has a significant share of cost, but he's heard good things about the drug and he wants to pay for it and move forward. So he takes it for a period of years, but he continues to get worse. There's no improvement in his symptoms, he's declining. So someone goes back and takes a look at his genotype report, and they notice that at the top, right under R117H and 5T, it says not applicable. And they look a few lines down and see that he does have 2 pathogenic variants, but they're not R117H and 5T. They are Q2X, which is a nonsense mutation, not eligible for modulators currently, and legacy name 1811 plus 1.6 kb A to G, not eligible for a modulator. So at this point, he and his insurance company have paid out a significant amount of money for a drug that didn't benefit him and potentially put him at risk for significant complications. So we got the original report from the lab that didn't interface into EPIC, and this is a copy of that report, where it clearly shows the 2 variants and no mention of R117H and 5T. So when I learned about this case, which was much later, I worked with the lab that had done the testing and interfaced the report so that they were able to fix this problem so that it didn't affect other individuals down the road. But obviously, I don't need to say much to say that this is a massive failure of the health system. So, in summary, this stuff is difficult. Interpret with caution. These reports are complicated. Do not hesitate to ask for help. If you're a typical CF clinician, you've been trained really well in the lungs and the digestive tract and all the ways that CF affects the body, but not in how to read these reports. Keep in mind that lab errors are rare, but they can occur. If the clinical picture doesn't fit, please investigate further. It may make sense to do more testing or talk with the lab further. As I think we've demonstrated over and over, many variants have several different names and are easily confused, including by insurance companies. You might have to test more than one person in a family in order to interpret your patient's results. And a lot of providers don't necessarily know this, but many labs have genetic counselors available on staff who don't work with patients at all, but are there to help the providers understand the testing that they're doing. So if you have questions, call the lab that did the testing, and they can probably get you in touch with a GC who can help. And that's it.
Thank you, Katie. And I think we'll ask all of our we'll ask all of our speakers to join us. Our app is working now, and we already have a few questions that have come in.
While we're getting settled, actually, I have a question related to, I think, maybe all three of your session or your talks, which is when something says pathogenic, does it mean it always causes cystic fibrosis? Or some of the reports that you wrote, that you showed kind of were a little confusing about that. Who wants it?
I would say the answer is probably it depends. So Karen showed that for the most part, as a generalization, the pathogenic and likely pathogenic equate to the CFTR2 designation CF causing. But for labs, especially labs that are doing a lot of testing and not a specialized CF testing lab, they're probably more oriented to the general ACMG pathogenic, meaning this is doing something bad to the gene, not necessarily this is causing the specific diagnosis of CF. So may or may not.
Yeah, I would just add, if you just read the fine print on the lab, sometimes they'll say pathogenic for a CFTR-related disorder, pathogenic for CBAVD. So you do have to know, I should have mentioned this in the talk. Thank you, Eleanor, for bringing it up. You have to know what it's pathogenic for, and usually that should be available in the lab report, but it does require a little bit of extra reading.
Thank you.
Can I add to that not all labs will agree on the pathogenicity, as I can tell others have experienced. So you may send a report, a sample to one lab and get a call of VUS, and another lab will call it pathogenic. If you call the lab, they should be able to tell you how they made that call, and it's not uncommon to have discrepancies based on how different labs use the ACMG variant criteria.
Which can be very challenging when you're trying to figure out whether somebody has CFTR-related disorder or cystic fibrosis. Their sweat chloride is intermediate, and you're relying on your genetic testing report to help you kind of tip the scales in one way or another. Thanks.
We have a question that asks about the poly-T tract. How does the 5, 7, or 9T variant affect genetic interpretation?
Everybody's favorite is the poly-T tract, yes? Are we all kept up at night by this? So generally speaking, 7T and 9T are not considered to be disease-causing on their own. And I'll just preface by saying, let us pretend that R117H is not part of this discussion, because when it comes to R117H, 7T does matter. We don't have an R117H, so what I'm going to talk about right now is just the poly-T tract. So 7T and 9T do not cause disease. 5T can, but it depends on the associated TG tract, which if you look at the CFTR gene is right next door. There's literally a string of Ts, 5 of them in a row, or 7 or 9. Right next door to that is a string of TGs. So TG, 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 9, 10, 11, 12, 13. So when it comes to 5T, if the 5T is right next to 11 TGs, that does not cause CF. If it's right next door to 12 or 13, it can. We, in CFTR2, we consider those varying clinical consequences. But what I just want to make very clear is you have to know that the Ts and TGs are in the same copy of the gene. So if you get a lab report that says 5T, 7T, TG11, TG13, you don't know what goes with what. And you need to either do additional testing or ask the laboratory to take a look and see if they can figure it out from their sequencing. But it is very important to know sort of which Ts and TGs are in the same copy of every gene. Because keep in mind, everybody with 2 CFTR genes has a poly-T and a TG tract, even if you don't have CF. So all of us in this room should have 2 different versions, well, maybe they're the same, but 2 poly-T tracts and 2 TG tracts. So you do need to ensure that the lab tells you which T and TG go together. That's the best I can do without visuals. That's a tough one. So for somebody to have CF, you mean? Right, so you would still expect that if you have a 5T, let's say with a TG13, so that together is considered a VCC. In the other CFTR gene, yes, you would either need a delta F or even another 5T, but yes, you would still need another variant in the other CFTR gene. So CF is still recessive, whether we're talking about poly-Ts or not. You still need something in one gene and something in the other.
If you just had a 5T with a 13 TG, you would be a carrier. You could.
You could.
I have a family that has 8 kids, and 7 of them now have CF, and their dad is homozygous for a 5T. He's fertile. He's asymptomatic, but some people with 2 5Ts might be symptomatic. You're a carrier for a 5T. 7's normal.
7T with TG11 is the most common. Like I said, everybody has a poly T and TG. That's the one you see most commonly in the general population, 7 with 11.
Can you remark on the R117H7T?
The poly T tract modifies the severity of R117H. So R117H with a 7 or a 9 is a fairly mild variant, but if you have R117H with a 5, it makes R117H worse.
And just of note, that's all actually searchable on CFTR2. So you can look up R117H on its own, but you can also look up separately R117H with 7T, R117H with 5T. You can look up 5T TG11, 5T TG12, 5T TG13, and get data from those specific combinations.
I also should add that not all labs report poly T, even if it's a 5, depending on why you told them to do the test. So if you told them to do the test for diagnostic testing because your patient has symptoms, they should report a 5T if they see it. But if you order carrier testing, some labs will not report a 5T even if it's there. That's going to vary lab to lab. Some labs make you check a box on a test requisition if you want the poly T tract or not.
And I'll just build on that not all labs that report 5T automatically give you
TG.
the TG tract. So
Even though you really need it to interpret
Yep.
the significance of it.
So it's good to have a relationship with the lab that you choose. And of course, there's so many to choose from, and some of that, it's patient-specific, what insurance they have. But yeah, developing those relationships either with your local genetic counselor or with your lab so that you know who to call if you have questions. But again, I think going back to Katie's point, if it doesn't seem right clinically, or CF does seem right clinically, but your test report isn't giving you what you need, keep asking the questions, because you might get the answer that you think you know already.
All right, our next question is there any way, simply by looking at the evolving nomenclature standards, to tell what class a mutation falls into?
If there's an X.
Mostly.
Most, yeah, that's true. That's actually true. If there's an X that's not in the last exon.
Yeah.
But you wouldn't really know that without going back to search what exon it's in.
Yeah, I'll comment on class because if I had to say the most common complaint that I hear about CFTR2, it's why won't you, for the love of everything, just list the class on the website? And there's a variety of reasons that we don't. Partially it's because we don't know class for every single variant out there. Some of it is because there are some variants, including our very favorite Delta F508, that actually have properties of multiple classes, right? So Delta F is most commonly considered to be a folding variant, so a class 2, but it also has properties of gating variants and conductance variants, classes 3 and 4. And so there are some variants where it's really tough to bin it into one class. And then also we don't list it because not every variant in the same class will respond to the same drugs. And actually the Delta F is a great example. We know Delta F508 responds really well to Trikafta, and it's a class 2. But a very similar, very close variant, I507del, does not. And so it would be incorrect to assume that all class 2 variants can respond to Trikafta, for example. The one comment I will make on this is, to Katie's point, most variants that don't require functional testing, so the ones that I went through, the frame shifts, nonsense, almost anything with an X, big exon deletions, canonical splice, those +1, +2, -1, -2 variants, for the most part, those do not produce any protein, and they're typically going to be considered class 1. There are, of course, some other proposals for a class 1A and a 1B and things like that, but generally speaking, if something is not going to produce protein, it's going to be a class 1. Beyond that, I can't think of any nomenclature.
I recognize an intronic, but
Still doesn't tell
It
you.
still doesn't tell you because it could be a 1 or a 5.
Right. I don't think that there's anything you can glean from the nomenclature that would help you interpret class.
Okay. How often should we be reevaluating patients with non-CF causing variants?
Clinically? Or doing genetic testing?
How often would you repeat genetic testing, especially for those cases that you don't have a clear picture while they are moderately symptomatic, that don't have like key factors, bronchiectasis, pseudomonas, that type of thing. And you get maybe a polyvariant or you get a higher function variant, but you only get heterozygous.
I can start this one.
Okay.
Because I think this relates back to zeroing in on the method from your report. And so the frequency with which you repeat testing will depend on how the technology changes for your testing and what your patient had. And so if your patient had your standard full gene sequencing and deletion duplication, you wouldn't necessarily repeat another sequencing test in any set interval of time. But if there's a new methodology that becomes available, and so if a lab is offering extensive intronic sequencing or they've added a new mutation to their panel, those would be the prompts to do testing. So it's going to be more patient-specific and test-specific than an overarching frequency of time.
And in general, there's hardly any reason to repeat exactly the same test again.
Yes, yeah.
So then, just as a generality, as of this moment, when was the most, how far back was the most significant change to methodology or the way most of your top genetic?
When did MAP?
want to just repeat the question?
Yeah, so generally, the question was, what was the most recent major change to testing platforms or methodologies? And it's hard to answer because it's, yeah.
I've had one lab tell me when I called to discuss the genetic report in detail to say that if the patient was tested prior to 2013, then it wouldn't be a bad idea to repeat.
That's going to be lab dependent.
Yeah, but I'd say that, I mean, so the major change in sort of sequencing technology was many labs switched from what we call Sanger sequencing to next generation sequencing or next gen. And that's going to be lab dependent, but I would say anything, you could probably say, as a rule of thumb, anything that's older than 2015, I was going to say
Yeah.
15, 16, it's probably worth repeating because there probably have been some updates in technology. I'll speak very specifically about the Mutation Analysis Program, or MAP. This is the initiative sponsored by CFF that gives free genetic testing for individuals with CF. There was a major change in technology for MAP in February of 2021. So prior to February 2021, MAP did full sequencing of the coding region and deletion and duplication analysis. Starting after February of 2021, or starting in February of 2021, they started doing full gene sequencing. So that includes all of the intronic sequencing that we learned about from Dr. Derry yesterday and from Jessica this morning, that goes through not just the coding exons, but all of the DNA in between. MAP also somewhat recently is allowing re-enrollment, meaning if you had it previously, prior to 2021, not that long ago, they would say, well, you've already had it, too bad. But now that they've updated their technology, they will allow re-enrollment if the previous testing that was done before the switch in technology did not identify 2 disease-causing variants. So you can re-enroll in MAP if you still have patients that have clinical CF but don't have 2 CF-causing variants.
I'm just going to add one other pro tip is that often they still have DNA from the original patient in their freezer, so you just have to reconsent them. You don't have to redraw and send another sample, which is really convenient and helpful.
I would say, you can tell me this isn't true, but I think outside of MAP, full gene sequencing is really common terminology that does not refer to sequencing of the introns. And so if you're working with a clinical lab outside of MAP and the test that your patient had was full gene sequencing, don't assume that that was equivalent to that intronic sequencing. It's just, I think, the terminology that means that rather than a targeted panel of mutations, they were sequencing all of the coding exons of the gene. And so those tiers, I think, could be generalized. You can look at, if you're deciding whether to retest, did your patient have a targeted mutation panel? Or did they have full gene sequencing? Did their full gene sequencing include deletion duplication? So like an MLPA or a CNV method. And then beyond that would be the current iteration of the MAP testing that would go even beyond that.
And I'll add that exome sequencing is looking at the exons or the blue parts of the gene. It does not look at the introns, the yellow parts.
So even though it's
So
all
it's not
genes,
more, it's more comprehensive for the rest of the genome, but not for CFTR. So if you think they might have something other than CF, then there might be a reason to do it, but otherwise it's not likely to help you. Genome sequencing is different.
So thank you. We have 4 more questions in the app that we'll work our way through and then take more if we can. I'm going to go with one that is somewhat related to our current discussion, saying there are lots of commercial companies doing CFTR testing. Any high yield points you can give us about which test might be better if MAP testing is unavailable?
Sequencing with del-dup is better than a panel for CF.
A lot of labs are using next generation sequencing in a del-dup platform, so that gives you good coverage.
And it used to be significantly more expensive than a panel, and costs have come down, so it's still usually more expensive than a panel, but the cost difference isn't as big as it used to be.
I would say other than that, just look at the experience of that lab with that gene. So the frequency with which your lab is going to give you a VUS or uncertain result is going to be somewhat tied to how much testing they've done for that gene, how much data they've accrued. And so if that, that's something that you can discern from reaching out to the lab and talking to them or looking up the information, but that would be another general factor to distinguish. And then, of course, there's whatever institutional constraints or patient insurance constraints are out there.
Another question is about copy number variants. You want to comment on what that is?
Can you explain what are copy number variants?
So that would be a deletion or duplication of a large chunk of the gene. And so when we looked at the diagram of like the exons and introns, the blue and yellow, generally speaking, a CNV would be taking out a whole exon chunk or more. And so those level of mutations typically aren't going to be picked up by traditional sequencing. They're maybe or maybe not going to be picked up by next-gen sequencing. And so oftentimes the lab would have needed to do a special ancillary method to find those. And there's a couple really common ones in CF. And so it is definitely relevant to make sure that your patient had CNV or deletion duplication analysis. Anything else?
We have 2 questions pertaining to CFTR2. The first is, what if a mutation is not in CFTR2?
So the CFTR2 database has about 1,600 different mutations or variants that have been reported to us, and 485 of those have undergone study by our team, and those are the ones that are searchable online. If you're looking for something and it's not in the data set, email us. So use that contact us button or find my email somewhere. Email our team, because most of the time, with very few exceptions, we actually do have a variant reported, but it just hasn't been studied by our team. But we're often still able to provide you some limited clinical information, or if we are in the process of functional testing or things like that, we can give you an update for the most part. It's not common that somebody emails me about a variant and I say we actually don't have it reported. Many of the things that people ask about are in the data set, they're just not necessarily looked at by our team yet.
Also, a shout out to our European colleagues that the CFTR France database also has a lot of information both about CFTR variants, and they tend to talk also about CFTR related conditions and the relationship with the genotype there.
Yeah, so check there too. If you don't find it in CFTR2, email us, but also check CFTR France. They do have a good number that we don't.
And then, Karen, regarding the determining a variant to be non-pathogenic in CFTR2, you're talking about the family studies testing the fathers. How long are the parents followed? For example, are they followed long enough to catch mild disease that might present later in life?
They are not. That was a sort of cross-sectional one-time study of the fathers, and the main thing that we looked at was whether they were healthy and fertile at that time. And really, if I'm being honest, the main question was, are they fertile? Did they need any assisted reproductive technology to have their children? If the answer is no, then that's pretty darn good evidence that one of their two variants does not cause CF. Because of course, as we know, the vas deferens really seems to be just maybe the most sensitive tissue in the body to reduction in CFTR function. And so certainly we've all heard of or seen patients that are perfectly healthy right up until they show up in an infertility clinic, and it turns out they've got two variants. And so we are not doing long-term follow-up on those fathers. It's a really fair question, though, because, of course, there are some variants, so 3849 plus 10 kb C to T comes to mind, that some people with that and another CF-causing variant are fertile. One of the things that we did require in our father study was to see at least two unrelated individuals with evidence of non-penetrance, to make sure I get all my double negatives right. But yeah, it's a fair question. We didn't follow them long term.
Then the other CFTR2 question is about if there are 3 mutations, how do you enter those into CFTR2?
So we do have a limited number of complex alleles that are searchable. So what I mean by a complex allele are 2 different variants that you know to be in the same copy of CFTR. And there's a couple that are known to go together pretty frequently. So we saw at least one example, the R74W and D1270N. That one's, those 2 travel together pretty frequently. And so for a small number of those, what we call complex alleles, you can look up the 2 together and your third variant separately. Now, if you don't know what goes with what, you can look up 2 of your 3 variants individually, and if any of them are part of a common complex allele, there will be a special note that says something like, this variant is often observed as a complex allele with so-and-so. That doesn't exist for every single complex allele, just a handful of the really common ones. There are some complex alleles that involve more than 2 variants in the same copy of CFTR. I'll just put that out there. One of our lab had a record of 5 variants in the same person once, and so there were 3 and 2. So that happens, and if you are confused about what goes with what, and either you can't do parental testing or you're not exactly sure what to do next, reaching out to your local genetic counselor if you have one, or the lab genetic counselor, or to our team, we'd be happy to help.
Sort of just tagging on to that, on the report you showed in the last, with the 2 on the 1 and the 3, and the most sort of modern explanation was possibly pathogenic. How is the lab telling us it's possibly pathogenic when they're seeing 2 mutations and not telling us that when they're seeing any other random set of 2 mutations? You know what I mean?
Are you saying like if you test other genes?
Like anybody who shows up with 2 mutations, like 9 times out of 10, that person could have CF. In this case, this person had 2 mutations, but the lab knew to say possibly disease causing.
So that happened to be an example of not those, so that you probably didn't notice at the top. That was from an entirely different patient who had 2 other variants that don't usually go together. So that, I think, is just their standard language. So it wasn't actually R74W and D1270N. It was actually 2 other variants entirely. I just pulled it, I went through a list of patients pulling some example reports.
So that lab, unless it's 2 copies of the same mutation, they're saying possibly.
Mm-hmm. It may be that patient that I had that example, because I couldn't find another one for that lab easily last night. It may be that patient that had testing didn't have a complete phenotype, and so that's why the lab was being cautious. I couldn't tell you.
And one more question about CFTR regarding functional testing. Can you explain what functional testing entails?
Yes, so we have limited time, so it's really tough to get everything in. When we talk about functional testing of a variant, what we're trying to determine is whether it affects CFTR, the protein's ability to conduct chloride. And that can be either because the protein itself is not made, so things don't conduct chloride if they're not made, so that's number one. But also if it's not spliced together correctly or things like that. And so for the most part, what we are doing with functional testing is artificially introducing a specific variant to a cell line, and then we use a fancy contraption that I know very little about called an Using chamber. And it essentially measures how much chloride is being conducted by that mutant protein. And we normalize it to a normal, healthy CFTR that doesn't have any mutations, and we report that as a % of normal or a % of wild type. And so just for some context, delta F508 conducts chloride at about 0.2% of wild type, so less than 1% total function. And we know from a variety of studies over the years that 10% of normal CFTR function is about the threshold of where we start to see CF. Now, 7, 8, 9%, you would probably see CF but milder. When you get down to 2%, 1%, 0%, that's where you see pretty classic pancreatic insufficient CF, early onset lung disease. I'll make one note about the functional testing. The stuff that we do related to CFTR2 specifically looks at chloride conductance. But you probably remember from CFTR biology that CFTR also transports bicarb to a certain degree, so we're not assessing that. And that, I think, is part of the variability with some of these variants, where maybe your chloride conductance isn't super, super low, and there might be other functions of CFTR that are impaired, and we're not really looking at those, mostly because chloride conductance is the main one that we're concerned about. But that's how it's done. The first round of CFTR2 variants were tested actually by Vertex in their lab, and then our lab took over part of the testing. We also worked with Phil Thomas when he was at UT Southwestern, and now CFF has actually conducted much of the testing. I think that publication is forthcoming of their results. So that's how we do it. It's laboratory-derived cell line testing. Are you talking about, so is the question, how do you order functional testing? You don't. You don't get to order that, I'm sorry. The functional testing that we do as part of CFTR2 is part of our analysis pipeline. And so typically we don't do that on an individual patient basis, except for if we are doing, we being the general we, are doing serotyping. So to determine how much CFTR function is there and does it respond to modulator drugs. But functional testing on an individual patient basis is typically not done. And the functional testing that we do in our lab is not from actual patient cells. So we use laboratory-derived cell lines. Some of them are Fisher rat thyroid cells. Some of them are human-derived cells. But it's a totally separate type of test than a clinical genotype or anything like that. It's not. No, I mean, if you have specific questions about a patient who you think needs functional CFTR testing, that can be a separate discussion, and there are a few research groups that are doing things like that, but on a typical clinical basis, it is not available. So nasal, well, other people in the room are going to know a lot more about this than I do. Nasal potential difference tells you about the patient in front of you, but it doesn't necessarily tell you about the individual mutation in that patient. So it can be used more on a clinical diagnostic situation, but it really doesn't tell you much about the genotype.
Because you're not isolating it to the one variant. That, like, functional testing is looking at one variant in essentially a vacuum. Like that's the only variable. And an NPD is affected by genotype, it's affected by environment, everything else that's going in. Yeah, everything else involved in that human. In the lab with a functional test, you're looking at one variant and controlling pretty well for everything else.
There are a couple of serotyping labs that on a research basis may accept patient samples and grow up cells from your particular patient and test the modulator response and change in chloride conductance. So it's out there, not everyone needs it, not everyone, it's not for every patient, but it's very helpful for select patients. So there are particular avenues that can be explored.
All right, we are at 1:31 right now. Thank you so much to our panelists.